Hi everyone, welcome. Please feel free to introduce yourselves in the chat. It's always nice to know the audience members well. Hi Hinda, hi Vesa. It's nice to see our collaborators in the audience as well. Hi Marcelo, welcome. Great. I think we can get started. So welcome everyone. My name is Smisha Agarwal, and I direct the Center for Global Digital Health Innovations at Johns Hopkins. I'm an associate professor of digital health at Johns Hopkins. Um, we can move to the next slide. We do have translations available on this webinar in Portuguese and English. So if you follow these instructions and choose the language that you prefer, we'll pull up the interpretation instructions a few times. Okay, so we can get started. We have a lot to cover today and an exceptional panel that has kindly joined us. This is the third in the round of learning webinars on the foundations for digital transformation for primary healthcare. This is part of the Digital Health Exemplars series supported by the Gates Foundation and Exemplars in Global Health. And digital health exemplars are countries that have scaled digital interventions and digital health systems to strengthen primary healthcare. We are focused on 5 countries as part of this effort, which are at different levels of digital maturity and have different types of healthcare ecosystems. Rwanda, Ghana, India, Brazil, and Finland. Next slide, please. And a multi-partner group is driving this work forward with different areas of focus. The learning insights that we'll share today is led by our center at Hopkins and eHealth Labs Ethiopia, as well as in close partnership with Africa Quantitative Sciences. Hinda Rutan is on the call, as well as University of Ghana and Francis Baba, IHMR in Delhi and Bangalore, and then finally EAPS in Brazil, as well as in close collaboration with Jarmo Rappanen, who's one of our panelists today from Finland. Um, Next slide, please. I'm moving us along so that we have really the bulk of this time to hear from our panelists. But let me start with our topic for today. As part of Exemplars, we've been really looking at the foundational enablers for digital transformation. And our focus today is on interoperability. The goal here is to really learn from countries that are at various stages of implementing a health information exchange. Next slide, please. The path to interoperability at the national level is it really depends on the country's context and health systems. Often interoperability is it tends to be seen as something removed from health, right? Something that traditional public health audiences think is not within their remit. But really, the goal of it is to empower citizens to access their own healthcare data and to strengthen the health systems in making data-driven decision making. So one of the key challenges to interoperability is that it is invisible. It is the pipeline. It is the layer that we can't see. And therefore, it's also underappreciated. It is also very costly to implement this, the gold standard. And so practically, the question that we are tackling today is how do countries at various stages implement interoperability in a way that is fit for context and in a way that is fit also for their purpose, because the purpose also changes from country to country. And so we are starting today, next slide. We are starting today with our thesis of these 2 key models, and we'll ask our panelists to really reflect on these in their comments. And so model 1 here is really focused on a single software for a specific use case that is potentially scaled across levels of care. This makes sense for some contexts. It makes sense for smaller, homogeneous countries where payers and providers are primarily from the public sector. We typically have a lot of island countries who join our webinars, and there are certain systems that absolutely make sense for them. Of course, these have lower upfront investments, lower complexity, but also have constraints in terms of data portability. And then the second model, which is really on the far end of this first model, is having a foundational data building block and creating a health information exchange, which is what the countries that are represented on the panel today, specifically Rwanda, India, Brazil, and Finland, have done. And we'll have a chance to talk to the panelists, even looking back 10, 15, 20 years of what resulted in that type of decision making and what was their journey to getting where they are right now. So this type of model is, of course, much more complex undertaking and requires a whole ecosystem of support. So with that, let me introduce you to our panelists for today. Next slide. We have Lena Khan from our center who will talk about the exemplar's findings briefly, followed by Dr. Garrett Mahel, who will talk about the work the WHO is doing for a reference architecture for interoperability. Dr. Alan Lebrique, who's the director of the Department of Digital Health and Innovation at WHO, is our discussant for today and will help bring all of our insights together and give us marching orders for where we go next. Professor Jarmo Rappanen is a vice president Finnish Society, but more importantly, he's been engaged with Finland's digital transformation for several decades and has the benefit of being able to look back longer with a longer time horizon. Dr. Paula Xavier dos Santos is the director of DataSUS, Ministry of Health, Brazil. Andrew Muhere is the acting chief digital officer, Ministry of Health, Rwanda. And then finally, Kiran Gopal Vaska is the joint secretary of the National Health Authority, India. We're absolutely delighted to have you all. Thank you so much for taking time and spending your time with us. With that, over to Lena. We will have a brief presentation by Lena Khan and Dr. Garrett Mahel, followed by some framing comments by Dr. Alan Lebrique. Over to you, Lena.
Great. Thank you so much, Smisha, for the wonderful introduction. So hello, everyone. My name is Lena Khan, and I am very excited to share some insights from the Digital Health Exemplar study with you. Next slide, please. So today I'll be presenting on 3 key themes from our cross-country insights, including the stages of interoperability and building a health information exchange, or HIE, the strategies to facilitate this adoption of interoperability across diverse or different contexts, and finally, the timeline and financing structure of a nationally scaled HIE called the Kanta services in Finland. Next slide, please. So here we present a snapshot of the 5 exemplar countries: Rwanda, Ghana, India, Brazil, and Finland. So each country's approach to interoperability is shaped by many of the factors that you see on this slide. These include large differences in population size, from just 5.6 million people in Finland to a large population of 1.4 billion in India, as well as variations in health system structures. For example, the private sector delivery ranges from less than 10% in Rwanda to over 70% in India. So throughout this presentation, we will explore how these different factors actually influence the way these countries have designed and implemented their interoperability strategies, including building their health information exchange, or HIE. So while Rwanda and Ghana are still quite early in their HIE journeys, India, Brazil, and Finland have each scaled their national HIE, which are called ABDM, RNDS, and the Kanta services, respectively. Next slide, please. So to dive in the first theme of our presentation, we present here a framework illustrating the potential pathway a country might follow to build interoperability and their national HIE. This may start with building foundational elements like health IDs and registries, as you see in layer A, moving towards the ultimate goal, or the North Star, of direct patient access and engagement with their health information in layer D on the right side of this framework. Next slide, please. The journey towards this ultimate goal is often supported by early and ongoing innovation and experimentation of digital systems and technologies, which provide countries the critical experience and knowledge needed to actually build a robust digital health ecosystem. For example, Rwanda is currently transitioning from a donor-funded vertical digital health tools to more centralized and locally developed electronic medical records. Next slide, please. So as we move along this interoperability journey in layers B, C, and D of this framework, we see that digitization often begins with using aggregated data to enhance visibility and planning at the national level. As the enabling ecosystem strengthens over time, including efforts in governance, infrastructure, and workforce, the interoperability journey expands across levels of care and towards more specialized health services. And this progression ultimately moves countries towards the ultimate goal of enabling patients the direct access and use of their own health information. Next slide, please. Across the 5 exemplar countries, we observe different stages of interoperability, as shown here on this slide. While all countries have established strong data foundations to support national health planning, India, Brazil, and Finland have further developed interoperable systems in their countries that facilitate data exchange across levels of care and health services, and have rolled out or scaled patient portals. Next slide, please. And so now we'll examine in more depth the unique approaches taken by each of our exemplar countries across the central layers of B, C, and D of the framework. Next slide, please. First, we zoom in on layer B. So we often see early digitization where it is limited to district-level systems that support national data aggregation. At this point, infrastructure and training needs are still relatively low, and only basic data standards may be needed at this stage. As an example, Rwanda and Ghana both use the centralized DHIS2-based health management information systems to aggregate and report data. Similarly, in India, the Health Management Information System aggregates data from over 200,000 facilities across district, state, and national levels. In Brazil, data from primary care electronic records are compiled into a national platform. I also just want to pause here to note that if you have any questions on any of the content or examples being presented, please enter your questions in the chat for our wonderful panelists to address. Next slide, please. Moving on to layer C, as digitization expands from the district to facility and community levels, systems now support point-of-care decision-making and longitudinal patient records. This expansion also adds complexity, requiring the use of patient IDs, facility registries, and standardized data formats. As this data moves between health services, so from referrals to laboratory and prescription services, there is an additional demand for more specialized data standards and clearer data sharing policies, with the goal of improving patient experience, care quality, and overall system efficiency. This is quite evident in India, Brazil, and Finland, where data from electronic health records are integrated seamlessly with the National Health Information Exchange, using international data models such as FHIR-based APIs and coding systems like ICD-10 and SNOMED-CT. As another example, in Brazil, the COVID-19 lab results were actually the first health service to be integrated within its national HIE RNDS. Meanwhile, in Finland, the Kanta system, it was designed from the start to support the exchange of a full range of patient data, including medical records, prescriptions, and lab results. Next slide, please. Great, finally, previous slide. Great, finally moving on to the final layer, layer D. Providing patient access to their health data empowers more personalized, informed, and equitable care, fostering shared decision-making between patients and the providers. India, Brazil, and Finland have all implemented patient portals like MyZeus Digital in Brazil or the MyKanta pages in Finland, both of which pull data from the National Health Information Exchange and giving citizens access to the medical records and clinical summaries. Next slide, please. Now that we have covered the potential pathways that these countries have taken to build interoperability and their own health information exchange, we'll move on to talking about some of the different strategies these countries have taken to facilitate the adoption of the HIE. So as you may recall from the beginning, India, Brazil, and Finland, the 3 countries with more defined pathways to national HIE, shows different levels of private sector involvement and health system structures. So as a reminder, over 70% of India's health sector is private, while Brazil and Finland have predominantly public health systems. Because of this, each country has adopted distinct or different strategies to encourage HIE adoption. Starting with government mandates, in a smaller country like Finland, the Ministry of Social Affairs and Health steers and regulates the health system. And both public and private providers in the health sector are mandated to comply with the national Kanta HIE layer. In Brazil's more decentralized health system, public primary care facilities connect to the national HIE RNDS, while the private sector integration remains more limited to lab results and prescriptions. As for financial incentives, in India, the government is supporting healthcare providers to integrate with national HIE by providing financial and monetary incentives and through microsites. This brings healthcare providers indirect benefits as well, including increased visibility and business development and opportunities. For guidance and testing, both India and Finland are offering sandbox testing environments for providers to test and align their products with interoperability standards before fully integrating these technologies with their national HIE. Finally, to ensure ongoing capacity building for sustained adoption of HIE, Finland has implemented pre- and in-service training for all public and private providers to effectively use the Kanta system. Next slide, please. So before I hand over to the next speaker, we're just going to turn to the final theme of our presentation, which is the timeline and financing structure of a nationally scaled health information exchange called the Kanta Services in Finland. So as Misha mentioned, one of the key gaps in understanding of the journey toward interoperability is the significant time and cost it takes to actually build an HIE. While many countries are still in this early stages of estimating these numbers and figures, Finland provides a almost 20-year horizon of the sustained investment in its HIE infrastructure called the Kanta system. So to provide a little bit more context, Kanta was launched in response to fragmented standalone EHRs that were not technically communicating with each other very well in the early 2000s. So in 2005, the government provided a lump sum of 21 million euros to build the Kanta system, as shown by the green bar on the left side of this timeline. As the Kanta system matured and new components were being added, its ongoing maintenance and operating fees are now funded through a hybrid model of user fees by pharmacies and providers, as well as government financial support. This is indicated by the light blue bars on the right half of this timeline. So this ensures a long-term sustainability model for the Kanta system. And today, 100% of all public health facilities are using the Kanta services, and around 60% of the population are accessing and using the My Kanta pages, the patient-facing portal of Kanta, on average per year. Next slide, please. So in summary, there is no one linear pathway to interoperability. The country journeys from our cross-country insights will be shaped by public-private sector dynamics, financing models, regulatory mandates, and incentive mechanisms, all of which together influence how systems are designed, integrated, and scaled over time. And with that, I will hand it over to Dr. Garrett Mahel to talk more about the WHO Guide Framework. Thank you so much.
Great, thank you so much. I'm just going to share my screen. Just give it a minute. Hopefully you can see that. Are you able to see my? Okay, great. Thanks so much. So I'm going to talk about the work that ITU and WHO are doing together on a reference architecture for digital public infrastructure and standards for health sector digital transformation. That's a long-winded way of saying we're developing guidance that builds on existing work and helps multiple countries to transition to utilizing standards and DPI infrastructure. And that's work that has been really emerging over a number of years and really will build on and learn from the country examples that many of which we're seeing here in the exemplars, but also work that has emerged through regional and other technical communities of practice that have really helped facilitate country capacity around understanding interoperability standards, understanding the set of services and the governance and the interoperability standards that are widely needed in order to be able to establish the health sector transformation that many of the governments are looking to. The work has been going on for several months now, and the intention is very much to ensure that there is a reference architecture, which means the specifications, the technical capabilities that will be needed, and the implementation guidance so that a diversity of countries that have are coming at this guidance are able to see themselves and be able to plan forward for the goals that they have as a country and really basing it on the work that may already exist in the country. It will also ensure that we leverage existing standards and specifications, but where there are gaps, we will define those as it relates to DPIs in the health sector. We want to be pragmatic. We want to ensure that countries are able to see the health goals that they're trying to achieve in the guidance and that they can come to this from a diversity of maturity, readiness states, and different starting points. Distinct perhaps from work that we have done in the past, we want to achieve testability. And so this is very much working from existing and emerging interoperability standards and the work of profiles that IHE has done and broader work that has been going on in the field for some time. The intention and the outcomes, the expected outcomes are guidance that will help facilitate capacity building at country levels so that they are able to invest in, coordinate, govern, maintain at a financial and technical level a set of essential digital capabilities that are relevant to the health sector and that they're able to connect to the other sectors where foundational DPIs might be in place. This is intending to really recognize the fact that countries are in a situation oftentimes where there are limited funds and increasingly so that they need to be able to increasingly empower and build the capacity at country level and leverage the finances that they have at their own country level. This work has a lot of assumptions, and I think this is really important. There is no country that is a digital greenfield. There's extensive lessons from countries. There's extensive investments that have taken place, some of which have led to digital capabilities that can be leveraged, and some of which are investments that need to be upgraded and extended. That wide spectrum of digital health maturity from countries that are using paper and have weak regulatory mechanisms to those with advanced federated health information system platforms, each of them have to be able to be recognized. Those different stages are part of the design of the reference architecture documentation. Countries often have siloed or donor-driven vertical systems in specific health program areas that don't have a data backbone, and that's an assumption that we've made, that there is a pathway that's needed to be able to help them transition over to the use of health information exchange through interoperability standards. Some governments we recognize prefer decentralized models due to institutional autonomy or federated health governance. And some other countries prefer a centralized model. We need to recognize these different pathways and different governance approaches. Many countries lack foundational DPI components, such as ID or payments or data exchange, or that they're in the nascent stages of developing those. So the documentation has to take that into account and ensure that the minimum functionalities and capabilities that are needed for the health sector are brought to life with a recognition that the foundational DPIs may still be being built. There needs national policies on data protection, interoperability, and consent management may be underdeveloped or not enforced. Another assumption is that countries need aspirational guidance, but they also need clear practical pathways to start implementation. Even where digital health tools exist, paper systems often persist. So the reference architecture assumes a diverse digital health landscape and is therefore being developed to be modular, maturity sensitive, and standards based. And it offers a pragmatic pathway for countries with limited infrastructure, but still being valuable to those who are looking to advance the systems they already have. It doesn't prescribe a one size fits all, but instead provides a toolkit of composable, modular building blocks that countries can use according to their goals, the regulatory context, and the capacities they may have. The architecture is tiered. It will support low resource settings with lightweight starter components, will ensure that there's guidance around how to migrate systems over to a unified data backbone that connects the different program areas through a common health model, a health data model. And it will offer health sector specific guidance, including the specs that work for the use cases that are prioritized by the country and are highlighted within this work. It really also needs to highlight the examples of how countries have succeeded in making transitions, and it will ensure that the policies and governance are brought to bear around each of these different areas. We recognize that health digitization may be influenced by a set of health sector goals that are driving the investments around digital transformation, and that might be in financing, that might be in supply chain management, it might be around ensuring that there's a health workforce that's trained and paid on time. It may be around getting to that personal health record, so that every person has their own record, or ensuring that there's continuity and quality of care. Other areas that are emerging, especially among some countries, are ensuring that there's climate awareness and resilience and response, whereas the traditional investments that have happened in digital around surveillance, response, and reporting are often foundational pieces that countries want to continue to invest in. These areas are ones, and WHO, and when we think about the reference architecture, we're really thinking about and working through this technical working group to design the guidance that is also going to be consistent with the approach that WHO has committed to supporting countries around, learning from a full stack approach, which is a comprehensive framework for digital transformation that emphasizes local technology and the systems that enable its effective use. It stands for the areas of open standards, open technology, open architecture, and open content. And we will be leveraging those components, such as the FHIR interoperability standard, the use of open technology that might serve as a starting point for countries, and of course, a quality assured content that can help drive that forward. The digital public infrastructure approach that we're taking recognizes that the health sector fits within a broader ecosystem of technical capabilities and constraints, and the DPA for health have to interface with these foundational components and functional applications. And that's really the focus here, is really the focus on DPIH and how it interfaces with these other components. The reference architecture is really intended to support a diverse set of pathways to adoption, recognizing that countries may be at different stages of maturity, different financial or technical constraints or capabilities, and that the governance approaches that they may take or the policies or the interoperability standards need to be recognized. We do want to get them to ensuring that they have a minimum set of capabilities to achieve those goals, and that the technical specifications are articulated and are clear to them. The format that we are using to document is one that will help both those in the health sector, but also those in the technology sector who may be adapting or building systems to meet those goals. The aspects here in the health DPIs are really the focus of this reference architecture work, but it does recognize the need to ensure that there is an interface with the other components, including the foundational components. That aspect of getting, for example, a personal health record requires understanding the existing ecosystem, understanding the financial and technical constraints, and understanding the policies or standards and regulations that may already be operating, and then looking to see to what extent they may have those capabilities already in the country. In the event of a country that may be very well established and have a sufficient level of maturity, there are a set of foundational and health-specific DPIs that can be leveraged. In the event that a country may not have all of those components, we still we ensure that the capabilities that are needed to achieve a personal health record are defined so that they can adapt existing components they may already have, and that they, for example, a digital health wallet combined with the terminology, combined with facility registry, maybe for those at the middle level of maturity may be sufficient, whereas those who maybe want to implement digital wallet for the purposes of, for example, yellow fever and the digital cross-border may be able to leverage a more minimal set of components and capabilities. I'll
Garrett,
just note as a final set of slides, and I'm just getting to the end, is that as you can see that these different DPI in the health sector combined with the foundational components help to achieve who the user is, where they're at, with whom are they being seen, and with what. And it helps to provide a consistent and fluid harmonization of the different capabilities that are needed. In the interest of time, I'll just note the interest and the work that we're doing. It brings together about 45 different experts from all regions of the world. And we're leveraging existing assets and resources and interoperability standards and guidance, including work that's been done by OpenHIE, World Bank, the UNDP, TOGAF, and the ITU WHO Platform Handbook. And we're trying to really establish this as a testable model and one that benefits from work that we've already done on SMART guidelines and the documentation that we've done in FHIR. We hope that this will be something that's available near the end of the year in a draft format so the countries can be able to comment and begin to make use of it. And I just want to thank everyone. And I'll hand back to
great, thanks, Garrett. And
thank you.
that's wonderful to hear more about the work, and also really nice to see such good alignment between the different pieces of work. So thank you so much for sharing those insights. Also, my apologies to the panelists. I realize we're waiting longer than we anticipated, and we're about to get started. But first, I just want to ask Alan Lebreek to share a couple of minutes of brief remarks about highlighting sort of the core challenges for interoperability and give us some initial framing remarks for the panel discussion. Thanks, Alan, and over to you.
Sure, thanks, Misha, and good morning, good evening, good afternoon, everyone. We appreciate your being here and your engagement and thought leadership, and really thanks, Misha, and to the Exemplars Project for bringing us together. You know, this is a discussion that's a growing global conversation. It reflects an important shift in tone of what we mean when we say modern responsive health systems, and the focus on the word systems, not isolated solutions. And you know, I reflect on what Lena said a moment ago about interoperability. And when we think about interoperability at WHO, interoperability is key to person-centered, accountable digital health. It's the backbone of respecting people and respecting their time and respecting their data, but not only in the patient care scenario, but how we use data for policy and improving efficiency. So when we talk about digital transformation, which is what this series is titled, we have to recognize that we're seeing momentum towards transformation as it applies to health system strengthening. And this is different. Transformation is not piecemeal solutionism. So I think what has brought us to this question of transformation is the multiple decades of progress we've seen in global transportation, trade, banking, and countries represented here today like Estonia, Finland, India, Brazil, Rwanda, Indonesia, who have over many years gradually developed and invested in digital ecosystems writ large outside of health as well. And so what we see is what can be achieved through strategic investments in governance, in clear policy frameworks, in robust architecture, and as Garrett mentioned, digital public infrastructure. And we ask ourselves, when these approaches, these systematic approaches are applied to the health sector, can we amplify the benefits to people, clients, and providers alike? So Lena pointed out, the exemplars that we have to date reflect complex and time-consuming journeys. Often there were some false starts and the need to retool and re-engineer and rethink. But I think what we want to learn and why we are doing the exemplars work and why WHO is working on reference architecture is because countries are asking us, how can we shorten or accelerate our reaching that destination? So the last decade was one of learning, and things have changed. And these trailblazers have made things be different going forward. You have made the road ahead much easier to travel for this coming decade. So what these countries that we'll hear from today have contributed is a knowledge base. They've contributed to evolving and growing standards, architecture. We heard about some sandboxes, and of course, the cost of ownership data that makes it a much less foggy road ahead. And that's why ITU, UNDP, WHO, that's why we are coming together to learn from these lessons and compile them into guidance and reference architecture to make the road ahead a lot easier. I think I just want to say a few words because we advocate for DPI-based, architecturally guided, and interoperability by design approaches to this thing we call digital transformation. And many of our member states are asking for support on which digital commons they should set up once and then use many times to support systems, ID, payments, health information exchanges, etc. When you think about what person-centered means, and I said this earlier, respect for persons and their data means building systems that are interoperable, not putting the burden of information on patients and providers. When systems speak to each other and people can access their own records, that's when we start to see person-centeredness. Now, it's important to acknowledge before we jump into the panel that there is great diversity among countries in their readiness, in their foundational capacities, digital, economic, infrastructural, and human. And I think success in building effective digital public infrastructure is not simply about deploying technology or a DPI in a box. It depends critically on strong governance, on clear legal frameworks, and digital stewardship. Who is steering the boat towards the goal that the country is trying to achieve? Together with sustained investment and reliability in digital commons. Without these essential commons, you can expect to have the same fragmentation in DPIs that we faced with digital public goods, with limited scalability and sustainability concerns. I think in the recent months, since January, we have seen over 40 countries of our member states reporting substantial collapse in critical digital health systems. And what these incidents reflect is the impact that these systems can have if they fail, compromising care, compromising efficiency, and preventable loss of life. And that happens when you have limited affordability and reliance on external solutions without sustainable local capacity. Over the last 2 decades, we've invested billions in digital health transformation and digital health solutions. But did we transform health systems? Or did we build up technical debt? And why did digital solutions that we've built over the last 2 decades not withstand the shock of external aid disruption? And I think that's why we are talking about transformation, architecture, and digital public infrastructure. The last thing I'll say, and then hand it back to Smisha, I think is the importance of how the landscape has changed. We not only have the lessons from these exemplar countries, but we also have robust developer-facing technologies and standards. We have development environments, we have global, open, robust systems, and the threshold for building interoperable systems has become significantly more accessible, making the use of interoperability first as a design principle much more feasible than it might have been over the last decades. So I very much applaud exemplars and those on this group systematically studying what has happened over the last decade. I'm delighted that we're partnering on this reference architecture together. But I think we need to continue to study the ingredients of successful digital transformation, because the timelines from initial investment to tangible benefits, the economic implications in the short and long-term scenarios are absolutely essential. The evidence that we get from these countries and the countries that follow in their footsteps will enable us to confidently advocate for investing in digital public infrastructure as a prescription for stronger, sustainable health systems. So let's have a good, robust discussion. And I'm really delighted for the 314 people who have joined us today to talk about this important area of work.
Great, thank you. Thank you so much, Alan, for those remarks. And without further ado, thank you so much to the panelists for your patience. We can get started. And so I think my first question is to Dr. Paula. If we can have the panelists, okay, online with their videos on, please. Okay. So Dr. Paula, the RNDS in Brazil has been in operation for nearly 5 years. Could you speak to what have been the priorities of RNDS? Where have you seen its greatest value? And then to Alan's point, every country has had a few missteps along the journey, a few course corrections. And so in your journey towards RNDS, what have been some of those course corrections? You know, what are some areas where you move forward and you said, well, maybe another way is a better way to proceed? So starting off with you, I'll encourage the panelists to keep their remarks brief so that we can have several rounds of Q&A and keep this conversational. Thank you. Dr. Paula, over to you.
Muito obrigada, bom dia, boa tarde, boa noite. Smisha, agradecendo a você, agradeço a todos os colegas painelistas dos países. Estou muito contente com a adesão ao webinário, né? Mais de 300 participantes, diversos países, né? Eu vou usar uma palavra que você colocou na sua introdução, Smisha. A Rede Nacional de Dados em Saúde, ela é desenhada de acordo com o Sistema Único Brasileiro. Não faz sentido criar uma plataforma de interoperabilidade que não reflita o próprio processo de gestão da saúde no país. Então, a Rede Nacional de Dados em Saúde, ela prevê a integração de todas as informações a nível nacional, passando por municípios, estados e o nível federal. O principal desafio, se eu for escolher um aspecto para dizer qual foi a abordagem, foi superar a fragmentação dos sistemas de informação em saúde no Brasil. O departamento ao qual hoje eu dirijo é responsável por mais de 400 sistemas de informação em saúde para diferentes finalidades. Isso além de sistemas próprios desenvolvidos por estados e municípios e sistemas privados. Então, jamais a gente teria uma visão nacional de dados de saúde se a gente não buscasse a interoperabilidade como forma de integrar uma visão nacional. Em relação ao valor, o maior valor de uso é disseminar esses registros que hoje estão nessa plataforma nacional para os cidadãos, para os profissionais de saúde e para os gestores de saúde, estaduais e municipais.
Thank you, Dr. Paula. And I think since you spoke about interoperability as a way of achieving cohesion between the over 500 municipalities and decentralized administration, maybe I can move on to Kiran, where you have experienced a very similar governance ecosystem in India where healthcare decision making is a state level subject. Could you speak to what were some of the factors that drove India's current federated consent manager based architecture um, as part of ABDM?
Thank you, Smisha. I think one of the biggest reasons is the size itself. I think it would not have been possible for any single system to handle the kind of large amount of data or transactions that would come in. And it would not have, and if we were to think of having a single system or a non-federated system, that means it would have also have to be mostly government driven, that to the federal government driven. And like you said, health is a state subject in India, run mostly by the regional entities, and who have their own challenges, their own preferences, and therefore giving that independence and giving that flexibility to the states was very, very important. And another factor was that right from the early days and the initial days when the digital mission was conceived, private sector participation was taken as an essential and an important component. So it was decided that government will not and cannot provide the solution for the kind of ecosystem that we want to build. And moreover, India has a tradition of very strong building software systems, and we also have been coming from the experience of Aadhaar and the various other layers of systems we have built. And in each of the cases, we said that government builds the foundational architecture, both the public and the private entities build the user level interface. And then this whole idea of building a federated architecture was also important to ensure confidence among the different participants, which is the public sector, the private sector, and the citizens. Where, in fact, I'm coming from a panel discussion today, where someone asked me, "Oh, you're creating so much data in ABDM. What are you doing? What are you doing with it?" So my first reaction to him was, "I have zero data with me. I don't keep any data. And the government does not intend to keep any of your data with you. Your data is staying in the hospital, in the lab, or any other place it is getting created. Either that hospital or lab has it, or you have it. The government has no data." So it also means that we are giving the confidence, because health data is very, very important. The whole idea of privacy and security becomes paramount. So we are able to give that assurance to the participants, the stakeholders, about the safety and confidentiality of the data by this approach. And then I think at the end of the day, it also pays to work in such a distributed system in such a large country. I mean, if I were to create one single entity that contains the entire data of all citizens, it would, I think, very soon start becoming unviable. Even the Aadhaar system we built, we said, okay, we'll keep only very basic minimum information, and everything else is a transactional data, and it is held by different parties. So the federated architecture was a very, very important thing. And once we said it will be a federated architecture, we automatically had to build a way of moving data from one place to another. So that is where the health information exchange consent manager comes into being. And this kind of architecture was essential because ultimately we also want data to move, data to be used. It's not a question of one hospital creating data and keeping it. It's a question of that data moving from there to the citizen, getting it, becoming a longitudinal history, and then that data also moving to the next doctor or next entity which needs to look at this information so that they can provide me better care. And then and therefore this whole idea of consent and HIEC, consent manager and health information exchange came in. And incidentally, our experience in the financial sector through the account aggregator framework also gave us the whole concept of a consent artifact. So we already had a consent artifact in place that was being utilized in the financial sector, where the account aggregators were capturing information about the banking data of different entities and were able to facilitate credit rating and other facilities as part of the overall financial system. So I think the strong requirement of running a health system in such a large country where the regional entities play a very important role. On top of it, the requirement of giving an assurance to every participant that their data is secure and it is not stored in one honeypot that anybody can exploit on a single day. And then the experience of building such DPI, digital public infrastructure based systems, where the principle of minimalism at the federal level of data is always has been a matter of practice. I think all these together drove us into devising this federated architecture and consent-based data exchange as part of the ABDM framework.
Great. Thank you so much, Kiran. Lots of excellent points. I have many follow-up questions that I won't be able to pose, but I want to just highlight these points for other panelists to pick up on if it's of interest, specifically in the role of private sector participation, which I know in Brazil has taken a very different journey towards incentivizing private sector. Also, the idea that governments building the foundational architecture and public and private sector will link with it. We will have a discussion on what are some of the strategies to actually encourage the public and private sector to link with that ecosystem, as I understand that that is a challenge in India currently of trying to get everyone to link with ABDM. A third point, and I think a very important point of the consent-based architecture, which is really the key is in driving trust and confidence in the system, which again is something that government systems may struggle with. So starting with that is a great place to start. And I think with that, we did start off with this idea of like, how do we approach interoperability in a decentralized governance ecosystem? And Jarmo, can I turn over to you, because you have in Finland a longer time horizon, and Finland too, a smaller country but also decentralized, but it has in fact scaled back, right, from a much higher level of decentralization to 21 well-being service counties. And so can you speak to, and I'm throwing a new question at you, Jarmo, so just to keep up with the panel, but can you speak to what were some of the interoperability challenges that resulted in the government saying, actually, this is too much decentralization and we need to scale back to 21?
Okay, thank you, Smisha, and thank you for the opportunity to share our experiences from Finland. Actually, you have quite many questions in that one, and I will start from 3 starting points why we are where we are in Finland now. So as you said, before Kanta rollout, we had a 100% digitized healthcare system. So in every institution, we have already a electronic medical record in place. But we had a fragmented system in different areas and in even different care sectors, in primary care and secondary care sectors. We had different systems in place. But the background idea of having health information exchange was the idea that the healthcare system should provide equal standards of care to all citizens, irrespective of where in the country they are living. And then the second point, from the professional's point of view, the systems should provide the healthcare professionals all the information they need at the point of care, not only from their own institutions, but also from other institutions. And then the third point is that the citizens, they should be empowered to take responsibility of their healthcare and well-being. And at the same time, with this, we wanted to increase the transparency of the service systems. As Kiran said, the trust is the foundation. Trust to the system is very important so that you can get the support of the citizen to fully utilize the system. Then about the second part, actually your question after that, what has been the experiences in Finland. So I would say that at the starting point, when we had these very fragmented systems, and we had before the great healthcare reform more than 150 different care providers in the public sector, and also we have 30% of the healthcare provision provided by the private sector. So 70% public, 30% private. So I could not see, even afterwards, any other kind of solution than to start with the strong government policies and the legislation and regulations, national certification, and building up the central facilities to have a national healthcare exchange in order to gather all the information together and share it to the professionals and also to the citizens through the citizen portal. But what I would say as a message here for the course of time is that do your legislation work before you start the technical implementation on any of these healthcare information exchanges. Because if we had made the consolidation of public healthcare service providers before, 10 years before, 15 years before, so we would have less work to do while making the national healthcare information exchange. Maybe that was the short answer at the end.
No, thank you, and appreciate that that insight. I also want to welcome Dr. Anna Sala. I see you're in the audience. We would love to have you join the panelist link. If you would like to join, Anna Sala Haddad is the Secretary of Information and Digital Health in Brazil. But not to put you on the spot. So we will keep moving along. Andrew, over to you. So in Rwanda, of course, the framework for the Health Information Exchange has been around since 2012, but it's being operationalized in the last few years with some early pilots. Can you speak to what has been the journey to going from standalone systems like DHI's 2 trackers, etc., to working towards this centralized electronic medical records? And what finally pushed that? What finally pushed the policy off the desk, right, into practice?
Yeah, thank you. So, thank you. I'm happy that I'm with the colleagues from different countries. I'm actually learning from also learning, but again, from a Rwanda perspective, actually, sorry, are you hearing me?
Yes, we are
Oh,
hearing you.
Good. So for Rwanda, actually, initially when we started with the ambitious architecture in a way that we wanted to achieve many things, which was really very good, but in reality, it was not really a problem from the ground. Actually, I liked the presentation from Brazil. Designing this architecture requires that you really design based on the context from the ground. And then from there, it was really very hard for us to have this interoperability working across, because we even had many requests or need from programs that pushed us to have multiple vertical platforms. Then it ended up everyone pulling and pushing for different platforms that are based from their needs. So I think like 2 years, we said, no, we could not move like this. Let us design the interoperability based on the patient journey. So when we are talking about the patient, what does the patient requires to move across different facilities, across being identified as one patient? So that one really helped us to come up with an architecture that is implementable. So we realized, given that we have insurance that covers above 90% of our citizens, we realized that our patient move from one facility to another. Then another thing is that it allows them also to go to the private facilities. So in that case, we needed to have one unified patient ID that makes the patient to be identified once from all these facilities. That is first. Then the second one, of course, is infrastructure. For you to make sure that you have that unified ID, you need to have electronic medical record running from this health facility, either public or private. So that's why we've been really pushing, and we are scaling this electronic medical record, which is decentralized. And as I said, currently we're in 2 provinces out of 5. And all these 2 provinces, they are connected on the Health Information Exchange. So as I said, when you look at the current way that I said is linked to the digital health reform of linking the patient to interoperability, it makes it easier to understand and also identifies problems that you need to solve. So I wanted to link this with the first approach and after this approach we're using. Initial approach that made us to move longer without this interoperability works. Most people were looking much more on the data for strategy, then it burdened the clinicians with a lot of digital systems to collect all this data. Then now the approach we're using is changing this mindset. Is the process producing the data that we need for strategies? That means the clinician will be only treating instead of using multiple and siloed platforms, but they'll be treating. Then at the end of the day, the system will be the one generating the data. Then the health information exchange will be the one that will be synchronizing the data across to make sure that at least even the patient can be able to retrieve his medical history. So that is, for Rwanda, we're using patient-based design, yeah.
Great, thank you so much, Andrew. And also nice reference back to the presentation on the two different models where there is this transition from that model one, which is scale up of singular software, to this model two, which is connecting the software with a health information exchange. And so maybe my last question is in this round is to Dr. Garrett Mill. Garrett, for the WHO's plans for reference architecture, you acknowledge that no one size fits all, that you're considering the level of maturity of each country. My question to you, also reflecting on some of the questions in the chat, are what would you suggest, and is the approach that a country that is largely donor dependent, let's say 50-60% of its funding from donors, what is the health information exchange approach that a country like that should take? I note that because HIE does require long-term sustained investments in health information exchange. In Brazil, we are able to look at how Brazil has transitioned from across 3 governments and yet been able to sustain the development of its interoperability approach. But of course, in other countries, that's not often the case. As the governance changes, priorities of donors changes, the approach and what is able to be continuously financed changes. And so I want to maybe ask you even a provocative question, right? And then I'll turn back to Jarmo to ask you the same question, Jarmo, in other contexts. But is there a non-HIE approach, right? Is there like a lightweight approach where if a country is not meeting the basic needs of its populations, that it should think about in its digitization journey?
Thanks, Misha. Thanks. That's a great question. And I think a number of countries are faced with this situation where they're trying to chart a path forward, and they have maybe considerable dependence or existing investments that they have been implementing and are trying to figure out the pathway forward. I think they need to take and they need to think through what is an approach that's going to help them move forward in the direction of interoperability standards, in the direction of either local or regional sustainability, and also the aspect of extensibility. So presumably, and I'm just making some assumptions here, but some of that investment that they have around digital systems is perhaps only focused in 1 or 2 health domain areas. But they will need to think through how can they build toward a model in which there is coordination to ensure that any new investments that come in start to take into account interoperability standards, start to move in the direction of data exchange, not data integration. Data integration is the bilateral exchange of data between 2 systems that may not use interoperability standards and may not be financially sustainable. So they need to start to think through and help chart a path toward greater sustainability. And as they're starting to make and think about data exchange through standards, but also leveraging digital infrastructure, they need to really coordinate with those donors and their own other ministries who may be making coordinated investments. who may be thinking about digital ID or digital financial transactions or data exchange and think through how they can leverage that to start to shift over to a model in which they grow their own digital ecosystem in a way that they can maintain and sustain in an increasing way themselves. And so I think it's a phased approach. It's not a one size fits all. It's a migration. And the aspect of, I think, the federated approaches, for example, that others have talked about on this call, in which there may not be a centralized approach. It may be a federated approach in which an individual becomes the mediator of the interoperability and the data that's needed to take from provider to health domain to facility. And they may be the holders of that data themselves if there's no centralized broader approach. So we need to think about a staged approach to that. And I think part of the reference architecture is helping through that phased approach that many countries, I think, are facing. Thanks,
Yeah.
Misha.
Thank you, Garrett. That was excellent. And also, I think in summary, what I heard is that the journey towards digitization, in fact, starts with several non-digital governance related stages, right? Making sure that we do actually have some of those foundational building blocks, even if they are non-digital. I see Alan doing 2 thumbs up, so okay, good. I think that's maybe that's a nice direction maybe for folks who are on the call, especially those who are just starting off with their digital journey, because often there is a tendency to over-tool, to over-digitize and digitize too soon, and perhaps keeping track of what those earlier phases are before you digitize is pragmatic and might reduce the waste of resources. So Jarmo, I'm going to turn over to you with this question on in the Nordic countries, some of which are very small, smaller than maybe one district in India, right? So very different ecosystem. There have been instances of a singular software, right? And could you speak to maybe the experiences of a few of those countries and what has been some of your observations of their journeys towards digitization?
Thank you, Smisha, for that question. So first, I would like to say that the choice of the model 1 or model 2, it's not the matter of size of the country. For example, in our case in Finland, we are only 5.6 million people, but still we have this federated or centralized model because of the situation that we had the digital systems in place, and our government had a policy in early 2000, late 1990s that let 1,000 flowers to bloom to make up innovation, etc. But there is the ultimate opposite also within the Nordic countries, and that is Iceland. Iceland has a population something like 350,000 inhabitants only, so it's the size of a medium-sized city in Europe, the whole country. And they have one system which is called saga, the fairy tales in Icelandic, and that covers all the public healthcare institutions, and also the private ones can join to that. And they have been successful in implementing this into the country. So they have a strong governance in the country, and they have a small enough population, and they have incentives to build up this kind of system. So in that case, the size matters. Then if you think other Nordic countries, I mean now especially Norway and Denmark, in those countries, they have made legislation work and regulatory work so that they have these regions which have a responsibility to healthcare. They are far less than in Sweden or in Finland. So in both those countries, they have only 4 regions which are responsible of secondary care. So they have been it has been possible for them to have systems for these regions, and even though built on that have a national information exchange of the summary information in the patient portals. But they have the problem because their primary health care is not within the same regimen there. So they have separate systems for primary health care, and they need a federated system in order to connect to the primary health care. So it's a kind of mixture of these 2 models. But I agree with the previous speakers that it's a long-term commitment, many years, 10 years effort, something like that, which should go over the various policy principles by various political governments.
Thank you. Great, thank you. That was very helpful. So my next question is for Dr. Paula. Dr. Paula, like in Finland, Kanta, as Jarmo said, is taking over the role of many vertical or program-specific health information systems. In Rwanda, we are in early stages of transitioning from program-specific health information systems to a more unified architecture, very similar in India. How is Brazil approaching this transition from legacy information systems towards interoperability?
Muito obrigada pela pergunta, Smisha. Eu queria também citar o Yarmon e o Andrew, porque apesar de realidades dos nossos países tão diversas, muitos pontos levantados por eles são comuns ao Brasil. Não é? Yarmon falou muito da motivação do empoderamento do cidadão ter acesso ao seu próprio histórico clínico de saúde. Andrew falou da importância de se ter um identificador único do cidadão para que se pudesse desenhar a interoperabilidade de acordo com a jornada do cidadão. Essas são questões comuns, mesmo que a gente esteja falando de países tão diferentes economicamente, em termos de população, mas que também são desafios enfrentados pelo Brasil, né? Então, eu queria muito chamar a atenção sobre isso. Sobre a sua pergunta específica de sistemas de informação, nós desenhamos modelos informacionais na RNDS não baseadas em sistemas de informação, mas sim em processos de saúde. Vou dar um exemplo concreto. Uma prescrição eletrônica de medicamento ou um atestado médico. Esse atestado, esse documento em FIRE, né, que nós recebemos na RNDS, ele pode se aplicar tanto a um prontuário eletrônico da atenção primária, quanto a um hospital, por exemplo, da média e alta complexidade. Então, a interoperabilidade é pensada muito mais de uma forma semântica de modelos informacionais do que necessariamente apenas informações de sistemas específicos. Uma outra ação que eu acho importante destacar é que os sistemas de informação desenvolvidos pelo Ministério da Saúde atualmente, eles já nascem integrados à Rede Nacional de Dados em Saúde, para que a gente não tenha que fazer o que estamos fazendo com todos os sistemas legados, que é criar essa camada de interoperabilidade. Smisha, eu estou preocupada com o tempo, mas eu queria também fazer um último comentário relacionando com o estudo que a Lena apresentou no início aqui da nossa conversa, do nosso webinário. A gente está falando de interoperabilidade com destaque na atenção primária, mas eu queria chamar a atenção que, se não fizermos a interoperabilidade, ela é justamente, como o Andrew colocou, para a jornada do paciente entre os diferentes níveis de atenção. Então, quanto mais estruturada estiver a interoperabilidade na atenção primária, mais fácil vai ser o acompanhamento desse cidadão também em outros níveis de atenção, como a média e alta complexidade.
Yeah, thank you so much. And thank you for putting the emphasis back on ensuring that sort of North Star, right, of ensuring that ultimately the goal is that the patient journey is smooth, that we can carry our health records and are empowered by our healthcare decision making. We've had a very rich discussion. We have a tradition of turning over to the panelists to pose really questions to each other. So I welcome our panelists to unmute and jump right in if you would like to. The questions can be to any of the panelists. I'll pause and give you a minute.
May I ask Paula?
Please.
You mentioned the patient journey and how important that is. So how have you ensured in Brazil that you could have this kind of lifelong medical record for each of the citizens? Because I see that was an important point that you mentioned.
And Andrew, could you come in as well, so that before Dr. Paula comes in, if you have other questions?
Yeah, actually, my question is to all the panelists. Actually, in our implementation, our experience is the big part of health information exchange or interoperability. It's non-technical, so it's much more on the nomenclature, having standards. It's much more on the security. Another one is making sure that you have capacity in the ground, but also adding value, like to make sure that insurers, they have a buy-in, private sector, they have buy-in. The layer have to add value to what they do. So I want to hear from them, experience from them on how they manage to make sure that the private sector are able to buy in on the health information exchange here.
Thank you, Andrew. So panelists, please mark the 2 questions. One is for Paula, the other one is for other panelists. Alan, do you also have a question?
I did have a question, if I might.
Please.
The question is about political resilience. And I think all of our great panelists today have demonstrated systems that have withstood political winds of change. And I think that beyond the technical aspects of architecture and interoperability, I would love to hear some of the insights, and maybe we can draw Ana Estela into this as well. But you know, what have been some strategies to ensure political resilience over successive administrations that often look to differentiate their political agenda and regime from others?
Thank you, Alan. And so the first question was for Paula, and then I think the last 2 questions have really been on non-digital features of interoperability. And Garrett, you have a question?
It's maybe a follow-on from Alan's, which is the financing of digital health systems has, for many countries, been a challenge. For your countries, what have been the enablers to ensure there's investment from government to be able to ensure sustainability in the systems that you have already? Thanks.
Thank you. And I'll just note that this question of political transition and financing across political transition is something we're able to study quite closely in Brazil, but it's wonderful to have Paula on the panel to speak to this. So we are throwing many questions at you. Please, over to you, Dr. Paula.
Muito obrigada, Yarmo, pela sua pergunta. É uma oportunidade até para compartilhar todos os registros que estão na Rede Nacional de Dados em Saúde, são disseminados em 3 diferentes plataformas, voltadas para públicos diferentes. Um aplicativo de celular, que é para o cidadão, que se chama Meu SUS Digital, o SUS Digital Profissional, que é uma plataforma web onde o profissional de saúde, no contexto de atendimento, consegue acessar o histórico clínico do paciente, e o SUS Digital Gestor, que são para secretários municipais e estaduais de saúde no Brasil. Eu queria até fazer menção que quando a Lena apresentou aquela evolução gradativa de disseminação, no Brasil, nós tivemos uma experiência um pouco diferente. Assim que os dados chegam na RNDS, eles são compartilhados nessas 3 plataformas, porque somente assim temos o valor do uso do dado, né? Então, como a RNDS ela traz uma visão nacional, independentemente do cidadão ter nascido num estado ou ter sido atendido, tomado uma vacina num estado e ter recebido o atendimento médico em outro estado 3 anos depois ou 10 anos atrás, todo o histórico clínico fica acessível somente no contexto de atendimento. Eu aproveito essa resposta para comentar a pergunta muito importante do Andrew, que é sobre essa troca de informações entre setor público e setor privado. Nós, do governo aqui no Brasil, recebemos na RNDS informações do setor privado. A saúde suplementar faz parte do Sistema Único de Saúde. Entretanto, não compartilhamos as informações dos cidadãos, as informações em saúde, com o setor privado. somente profissionais de saúde, de setores público ou privado, no contexto do atendimento. Essa foi a forma que a gente, no momento, definiu para respeitar a privacidade e uso ético da informação em saúde no país. Por fim, Alan pergunta sobre a resiliência política. Essa é uma enorme preocupação no nosso país. Então, entendemos que a Rede Nacional de Dados em Saúde não deve estar sendo sustentada apenas por um aspecto normativo do Ministério da Saúde, mas como uma política pública de Estado. E, nesse sentido, a RNDS hoje temos um projeto de lei tramitando no Congresso Nacional Brasileiro e também um decreto que será assinado pelo presidente Lula nessa gestão do ministro Alexandre Padilha, definindo a RNDS como padrão de interoperabilidade nacional. Desculpa, Misha, mas só para não deixar sem falar também sobre a questão do financiamento que Garrett levanta, com a criação da Secretaria de Informação e Saúde Digital, nós temos um programa que se chama Programa SUS Digital, que é a primeira vez que são repassados recursos financeiros do nível federal, da União, para governos estaduais e municipais para promover a transformação digital. Obrigada, desculpa se me estendi.
No, thank you. Those were a lot of questions to tackle. I think as an external entity, one of our observations has been how the financing approach in Brazil and the close alignment between with the primary healthcare secretariat has ensured that facilities in rural and remote areas have the infrastructure as well as the personnel that are incentivized. And that has really driven the digital transformation also in rural and remote areas. So appreciate that. Kiran, over to you to respond to these many questions. And if you'd like to add some of your own, please feel welcome to.
Thank you. I think fortunately, we haven't had much of political change at the highest level. So the policies continued. But like I mentioned, the states have seen a lot of change, even in the last 5 years of the existence of the digital mission. But I think wherever the change has happened, it seems to have happened for the better, because the aspirations or the promises that the political change brought in, invariably wanted to have an improvement in the health system. So any government or any change in the state level you have seen, we have observed that the states have actually done better than what they were earlier doing. So that has been anyway a blessing in disguise for us. I think more than political resilience, what also is a bigger challenge for us is the resilience within the ministry itself. Nobody is willing to wait for the digital innovation or digitization to dawn and the whole digitization of the entire system to happen. There are priorities, there are current challenges that everybody wants to address. And in fact, sometimes states tend to run away with their own approach to digital health, let's say, for example. So I think the greater challenge is in ensuring that all of these entities are actually moving in one direction or one specific way in which we want them to move. I mean, and then there is also this requirement of creating value from time to time. And without creating value, I think incentives are only going so far. But the UPI has taught us that if you make it useful, they will use it. Initially, yes, there were a few incentives given in the form of cashbacks. But I think today it's more demand-driven than supply-driven. And as for financing, I think it is a very, very important question. In fact, the next version of ABDM 2.0 from 2026 to 2030, will perhaps be focusing a little bit more on this, because now states or different parties are asking about, okay, we've been able to do a little bit, you make us what you call you made us create the project management units. We have done a few pilots, or we have been able to digitize a few hospitals. But if we want to sustain it, if we want to take it forward, a lot of investment is required. And I think the challenge, or rather the what you call the effort now, will be to make sure that we also pool in or converge with other programs that we have, like the National Health Mission, which is such a large program with such a big funding. I think our success will also depend on how we start tailoring these programs, the funding for these programs, into more sustainable financing for the state, so that this can happen further. I think, I mean, creating value is one way where we can start keeping the states interested. And I think at a regional level and at a city level, perhaps if we start nurturing this idea of a digitized city or a digitized state, where, I mean, health system, from a health systems perspective, and the states and cities start running missions of their own, in the sense, with, of course, aligned with the national image. Like, I think the cleanliness drive in India taught us that. I mean, the Swachh Bharat mission, although a mission that was started at the national level, you will now really see champions at the state and the city level, which are actually driving this change. I think that approach of creating value and taking it more regional and finding creative ways of channeling government funds, I think, can keep this sustained for a longer time,
Thank you.
until it reaches that tipping point.
Yeah, thank you. And I see Alan quoted you, and I emphasize, that if you make it useful, they will use it, which I think is a nice summary of all of the challenges with I think adoption of this sort of data lake. Yarmo, I want to turn over to you, please. Oh, I see you have your hand up. Perfect. I think you're able to speak to several of these points with a much longer time horizon. So please, over to you.
Yeah, for the benefit of time, I try to speak shortly now. But anyway, thank you, Arthur, for making the question about how to make both players, I mean the public side and private side, to work together and sharing the information. I think it needs both demands and incentives, push and value. So, for example, in our case in Finland, we have a legislation that electronic prescription is the only legal way of making prescription. So if you have a practice and you wish to make prescription, you need a digital system which is connected to the national one. But on the other hand, you can see the added value. You can see the creation of value when you receive information to your private practice also from all the public institutions. So you have the whole history of the patient available there. So you can see that you benefit from the system. So it's both sides. Then about the political resilience over the changes in the government, I think that one of the key points has been the discussion with all the stakeholders, and it's also long-term investment. You need a lot of work groups to do this discussion over the time period. That's one point, so that there's a common understanding what to do, what is need to be done in our country. And then you need the structures. When you have a moment, then the administration, the ministry, they should be clever. They should start a kind of authority or agency or whatever that is financed to do the task, to do the rollout, to do the work. And then when it's established, it will roll, it has the finances, and not the next government. They don't dare to stop the movement when it's going on. Thank you.
Again, another quotable quote of they don't dare to stop the movement when it's going on. So, okay, we are unfortunately at the end of this panel. I have managed to make it through less than 20% of my questions, but it's been a very valuable discussion and one that I hope will continue beyond this webinar. I think we have a lot of deep dives into a lot of the questions that have been articulated here as an opportunity to really observe from an outsider's lens how countries are approaching these different questions. And the work from exemplars, I don't think this was said at the beginning, it's about several hundred interviews from across these countries. So it's really drawing on insights from these experts who are implementing and rolling out these systems. With that, I want to turn over to Dr. Alan LeBrique to please help us contextualize what we've heard today, articulate core learnings, challenges, and recommendations all in a few minutes. Thank you, Alan.
Smisha, you're going to gain a reputation for asking impossible tasks of your panelists and your attendees. But this was a fantastic discussion, and I'm echoing a lot of folks in the chat who have been weighing in with a very similar opinions. So congratulations to the team. And it's through these discussions and conversations that we move forward our thinking, our research agendas, and understand that the road forward can be easier than the road behind us. And I think I just want to take a moment to thank all of the speakers today on the panel who I think highlighted through their own hard work and journeys how we can hope for a smoother road ahead thanks to the many dragons that they fought on their digital transformation learning adventures. So I have 5 points, and then from the discussion today. I think first is interoperability is not just technical. It's foundational to person-centered, accountable health system. As many of us have reiterated in various remarks today, it's about how we respect people's time, rights, and data. And I think Jarmo, you give a really great example of, and as did Paula, how being able to collect information from patients and reuse that information multiple times, massively amplifying the value of that data to improve that person's health journey. It's not easy, it's not inexpensive, but it may be a way to accelerate SDGs as well as country goals at a time when we have a shortage of funding, a lot of very, very terrible distractions in geopolitics, and health challenges are only going to get more complex with the tsunami of NCDs ahead. So number one, interoperability is not just technical. Number two, digital transformation. The title of this talk or this webinar is not solutionism, it's systems change. And so to succeed in system change, we have to invest in more than just the technology. It's governance, policy, architecture, and when possible and appropriate, digital public infrastructure, not just apps and pilots. Third, we are paying off, and I'm sorry to keep coming back to this, but in the last 6 months, 40 countries have lost mission-critical digital health systems that we claimed were built with digital principles and inclusiveness and equity. But these systems' failure points more than ever to the fact that too much was built without sustainability, standards, or resilience in mind. Emergencies in the past have demanded speed, but we need strategy and we need investment in people and systems now. Fourth is the bar, thanks to your learnings and thanks to the infrastructure, the standards, the sandboxes that you've helped to create, has made the bar lower than ever, right? So countries like we're seeing in Kenya, like we're seeing in Indonesia and Malaysia, are able to adopt mature standards, use developer tools, and the shared architectures that you've pioneered to accelerate their journey into transformation. And then fifth, but I think most important, and this is where Johns Hopkins and partners come in, is that evidence matters, especially for hard choices that are being made by governments, by ministries of finance. So clarifying cost benefit timelines and risks, giving policymakers the confidence to back long-term transformation over short-term fixes is the kind of evidence that we desperately need in the policy arena. And all of you are the ones who provide that for us. So I hope I've met your ambitious task, but I just want to say thank you for hosting this, and we're looking forward to collaborating with all of you.
Thank you. Thank you so much, Alan, and thank you to our panelists for joining. I know this was a lot of time. I see that the attendees have also hung on despite the 90 plus minutes. And there are some few links in the, and Lena, if you want to pull up the barcode, there are a few links in the chat that are propping up on more access to this work, as well as if you'd like to continue engaging with the various learning engagement opportunities that we're hoping to facilitate through this. So thank you again, everyone, for your time, and thank you very, very much to the panelists. Please take care, and we'll end the webinar. Thank you.
Thank you.
Thank you.
Everyone.
Thank you all. Bye-bye.
Bye-bye.
Thank you all. Bye-bye.
Bye.
Thank you. Thank you.